session. We want to stay on time. So our next session is the Patient Advocate Certification Board, and they're going to talk to us about their job function analysis study that they did earlier this year. So this will be really interesting to see where we are and where we're going. So I'm going to turn it over to Chris North, who actually was the inventor of this survey.
Thanks, Ann. I was not the solo lone inventor. No. So, good morning, everybody. Glad to be here. Feel free if you need to get up and get a little bit of coffee and stretch your legs. It's intense sitting as we keep moving forward, but I'm going to keep going here this morning. We've got lots to cover. So this morning we're talking about, many of you have probably filled out the job task analysis survey that came around. And so this morning we're going to talk a little bit about the job task analysis, what it was all about, and explain a little bit about that process. So I want to start off with the objectives, since you do get a continuing education unit for this. So this morning we're going to explain to you the results from the survey and the future impact it will have on the certification exam and the continuing education credits for all of you who are board certified. Talk about the impact of the findings on the workforce for patient advocates and describe how PACB will go about using these results as we move forward. We have a lot of information. I'm going to go through the slides relatively quickly. I want to say that all of this information will be on the PACB website. So if you feel like, whoa, we're going through all of these slides quickly, there's a lot of data, there's a lot of information, please know that all of this will be out on the website. It will be available to you.
Hold on one sec, Chris. Everybody that is in here, though, this is such great and important information, so quietly chat in the chat. I really want to give PACB and all their work our ears because they've put so much work into.
Thank you, Rachel. So I want to start off by talking a little bit about who PACB is for those of you who might not know. We are a national certification body for patient and healthcare advocate professionals. We are a not-for-profit 501c3 organization, and our mission is to promote a standard of excellence in patient advocacy through credentialing and standard setting. Our mission, or our vision rather, is to have board certification for all patient and health advocates. So we hope that those of you who are not yet board certified will consider sitting for the credential and getting yourselves to become a BCPA in the future. What is a job task analysis? A large undertaking for starts, but it's also a requisite for being a certifying body. Any agency, any organization that offers a certification exam must do job task analysis. And it's a descriptive assessment that takes a look at what the job-related competencies are for a given profession. And it's used to establish what the knowledge, skills, tasks, and abilities are for any given profession out there. And these job tasks and skills and abilities are then related to whatever exam is developed for the certification. The job task analysis is something that is required by the certifying body that certifies certifying bodies. That's right. We who create certifying exams get certified by a certifying agency, and that agency is the Institute for Credentialing Excellence, or ICE. Not ICE as you might think of for people who are in from other countries, but the Institute for Credentialing Excellence. And they require that we do this process to make sure that what the credentialing exam is testing is actually what the profession does. And so the JTA was created to show that the current knowledge, skills, and abilities that we are testing for is actually what patient advocates do. And these knowledge, skills, and abilities are broken down into performance domains. And so those of you who have taken the BCPA exam know that we have a set of domains. And the question is, are those domains still the proper domains? And then are the tasks and the skills and the knowledge related to those domains still appropriate? And so we take those domains, and under each domain, we look at what are the tasks that patient advocates do. And for each of those tasks, what are the knowledge and skills necessary to do those tasks? And it's not one and done. So while you all took the time and effort to fill out what was a somewhat arduous questionnaire, you'll get to do it again. Because ICE requires that we do this every 5 to 7 years. Because as you all know, the world of patient advocacy changes. Tricia stood up here last night and showed us her crystal ball and showed us how things have evolved over time. And the career and the path and the work that we do evolves. And so every 5 to 7 years, ICE says we must do it again. And so all professional organizations continue to do this work. And so in 5 to 7 years, we'll come back and we'll do it again to make sure that, again, we are testing the most relevant knowledge and making sure that our exam is accurate. So the information that we get guides the exam that we give to make sure that we are testing the most job-related and concepts, and that our exam has content validity. In other words, are we testing what we claim our advocates do? If you are a BCPA, and as Michael just alluded to, you say that you're certified, can we indeed say that you, with this certification, do what patient advocates do? And that's the important piece of all of this. So how did we do it? We put together a task force, a very diverse task force, to put together and start the process. And our task force was made up of the people you see up here on the screen, and they included people who are physicians, nurses, academicians, attorneys, private advocates, who work in a variety of fields, who could bring to bear all of the different kinds of issues that we would face. Legal issues, medical issues, people who could do the in-depth kind of literature and research and statistical kinds of elements that we needed, and we began the process. So we started off. We developed a list of the jobs that people do. We used our skills. We talked to advocates that we know, gathered from subject matter experts. We looked at the related knowledge, skills, and ability statements that we already had. We looked at knowledge, ability, and skills statements from other organizations, like many of the ones that you belong to. We looked at job statements. We pulled up job descriptions from every single place we could find job descriptions about what it was to be a health navigator, a health advocate, a patient advocate, and all related types of descriptions. And then we began to fill out this really robust description of what it is that patient and health advocates do. We used survey results from other kinds of surveys that we could come across, literature reviews. And we began to then identify what some of these skills were. We then had to decide who were we going to ask to take this survey. Not just BCPAs, no. We wanted anyone who was working in any kind of a field related to patient advocacy. They might not call themselves patient advocates. They might call themselves navigators. They might call themselves any number of things. We didn't care if they were independent. We didn't care if they were working in hospitals. We wanted to get the broadest scope of individuals working in this field that we could possibly get. We wanted to be as inclusive as possible to get as much information as we could. And so, again, the widest depth and range of information possible was the goal in capturing the information that we captured. So how do we get these people? If you're a statistician, we used a convenience snowball sample. If you're not a statistician, what does that mean? It means we went out there and we started off with a list of people that we knew where we could go to find people. So we used organizations that we knew had patient advocates that were members of them, and we said, we're going to give you, we looked at GNA, we looked at NAC, we looked at the smaller, we looked at MACA in the Arizona group, and we said, we're going to send you this survey. Will you send this out to all the people you know? And then we said, convenience-wise, all of the people we know, will you send it to all the people you know? And will you ask them to send it to all the people they know? And using that sort of network snowball, can we get some momentum going and gather as many people as we can? That's what that means. And through that distribution process, how many people can we actually reach? By people sending it to people, sending it to people. We had the survey set up so that no individual could answer the survey more than once. So you might have gotten the survey from 5 different people you know because they said, oh, I know this person. And you may have received it from more than one person, but there was no way for you to fill that out more than once. So we ensured that we couldn't get duplicate information. So then we had to figure out, how are we going to create the content to go on that survey? Through our processes, starting off with our initial lists, we began to identify major classification of the tasks that patient advocates do. And so we compiled this list of knowledge, of skills, of abilities, of the things that you all do and the work that you do. We started with our own PACB list of the domains and the ethics documents that we have. From there, we began doing literature reviews, combing all of those job descriptions, talking to people, and we came up with this initial list. Delivering patient advocacy services, access, finance, and management of healthcare services, coordinating services, adhering to ethical, legal, and practice standards, research, referral, treatment options, hospital or facility-based tasks, psychosocial concepts and support systems, patient advocacy skills and abilities, communication and interpersonal relationships, and thus began the refining of the process. From there, we said, okay, what tasks and skills do people need to begin to do those things? And so we looked at these literature reviews. We looked at a comprehensive inventory of patient job descriptions. We looked at government databases. So we went to the Department of Labor, and we looked at the jobs that the Department of Labor has and picked anything that was remotely close to the work that we do as patient advocates. And we pulled out those jobs, tasks, and knowledge pieces. And we compiled and reviewed, and we put together our first sample survey. We then convened 2 subject matter expert groups. Some of you were on those subject matter expert panels. Our first panel met twice. Thank you, thank you, thank you to all of you who served on the subject matter expert panels and helped us review all of these comments and these statements. And we went through item by item by item multiple times. What sounded redundant? What could be combined? What needed to be thrown out? Which one needed to be moved to a different category? Which one needed to be in more than one category? Which ones shouldn't be in this category? The committee came back. They revised it. They rewrote it. Then after the first meeting, the first subject matter expert group reviewed twice. Then we revised it. We brought it to a second subject matter expert group. We did it again with the revised survey. We got their feedback. And we finally came back with their feedback, and we came up with a survey. What we finally came up with is this set of task domains. Delivering patient advocacy services. It had 35 task statements. Access, finance, and management of healthcare services with 25 statements. Coordinating services with 42 task statements. Adhering to ethical, legal, and practice standards with 10 task statements. And hospital or facility-based tasks with 34 task statements. That's a lot of statements. But that's what we felt was necessary after all of our consulting to represent what we do. The final review by the committee came up with these knowledge statements. healthcare access, finance, and management with 22 knowledge statements, psychosocial concepts and support systems with 20 knowledge statements, patient advocacy skills and abilities with 28 knowledge statements, ethical, legal, and practice standards with 9 knowledge statements, and communication and interpersonal relationships had 14 knowledge statements. We initially put our survey out in February of 2021. We were hopeful that COVID, having people in lockdown, might lead to, you have a lot of time on your hands. We were hopeful that that would help getting people filling out our surveys. We launched it with the help of the Alliance for Professional Health Advocates, Great Old National Advocates, Health Advocate X, NAC, and then a variety of other individuals and organizations, again, to help with that snowball sampling. And so we sent this survey to just about anyone and everyone that we knew in the patient advocacy world to help us spread the survey out and around. We sent out multiple reminders to get people to fill it out. We finally closed the survey down in August of 2021, the last day of August. I'm going to turn it over to Danielle. I will let her introduce herself. She's going to go over some of the results with you and tell you what we found, at least thus far. We're still in the process.
You haven't flipped any of these over,
No, I
have
haven't
you?
flipped the pages.
Okay. All right. Okay. Okay, so a bunch of you out there probably know me. I know Robin, if she's still in here somewhere, she's one of my data geek friends. But I'm here to tell you folks, this is like being locked in the data eat yourself to death buffet. Because the report, the final report, the initial report that we got out of Qualtrics, which was the software data that we, or the software system that we used to collect the survey results, the report was almost 400 pages long. And we have literally been analyzing and analyzing and analyzing, and we've used a number of psychometricians, and there's still so much more work to do. So what you're going to see today is just a very brief, what we're calling a phase 1 report. And we will be convening a new SME panel to validate some of the results from phase 1. So if you're interested in participating in that subject matter expert panel for this next phase, please send me an email, give me your card, give me a call, whatever, because we'll definitely be starting to work on that here pretty soon. So what we found was, of course, that we had 405 total survey respondents, and of those, only 138 people actually got all the way to the end. It was a very long survey. And the reason it was a very long survey was because this is the first real data collection tool that PACB had ever been conducted in the field of patient advocacy. The initial study upon which the exam was built was as much data as was available at the time, but it was not a fully fledged psychometric study. But all professional practices start that way, and so we modeled this particular study after a lot of the work that Ann knows Hussein Tahan and other folks who have brought new emerging professions like case management and those kinds of professional practices from their very beginnings to very well fleshed out kinds of professional organizations now. So we were very detailed and very slow in how we went through this process. So anyway, we ended up with 138 responses that we could use. I will tell you though that even with, when we ran the statistics, of those that didn't finish the survey, it still didn't really skew the data. We did the analysis across the survey, and even if you included that data, it really didn't skew any of the results. They were still consistent with reliability and validity. So anyway, it was a small number, And I think I said all that. So, okay. So there you see our reliability coefficient was almost perfect, which means that there was extremely strong consensus among everybody who took the survey that the results were valid. And again, remember that we were very, very intentional in making sure that the subject matter experts that put the survey together represented all the practice settings and all the diversity that makes up the practice of patient advocacy. Okay, so we're going to go real quick through these slides because these are all going to be available on the website, and you can see the actual tables and the data and all of that. And there are also, we don't have the table, there are a few crosstabs that we have that we'll talk about briefly, but we don't have them on the slides simply because they're kind of difficult to follow and you need a little bit more explanation. But we had a psychometrician take a look at differences between work settings and whether or not there was a difference in the importance and frequency of people that worked in hospitals, people that were in, that specialized in billing and insurance. And we did find that there were a few areas, a few of the task domains where there were some statistically significant differences. And so that's one of the things that subject matter expert panel is going to be looking at as we go forward with this next review. Okay, so I don't think there's any real surprise on this little chart here that we're predominantly female, that we're predominantly white, that we're predominantly old. So, although I can tell you that it is starting to skew younger. So I'm very excited about that. And because I look at every single application that comes in to sit for the exam, we are starting to see a lot more diversity of the people that are applying to take the exam and a lot more diversity in age. So that's all very, very good, and I couldn't be more pleased to see that change from back in 2018 to where we are today in 2022. What is your job title? There is a table in the report that actually breaks out in more detail what goes into these. We had to sort of summarize these, but these are basically the key categories of job title. And where are you employed? So you can see the far left, I don't know if you can see the labels, but they're volunteer on the far left, a government employer, a nonprofit organization, a for-profit organization, or self-employed was the largest group of the people, at least, that participated in the survey. Employment status, of course, being employed or self-employed, working part-time, unemployed, a student, and retired. We actually have a fair number of retired people that still do advocacy work. A lot of them do it on a volunteer or pro bono basis. Primary practice setting. Now, it's important here to note that, at least in the survey, the way it was described, independent meant you were a solo practitioner or a freelancer of something of that nature. Private meant that you worked for a private firm of some kind. That could be an employer that employed other advocates, or it could be like a nonprofit organization that served a specific community or a specific disease state or something like that. So that's the differentiation there. Medical, of course, means that you work in some kind of a facility, which could be a hospital or any other kind of facility. Other, and then you can see at the bottom, other includes academics, employers, which is what Colleen was, those kinds of things she was talking about earlier, insurance, military, so forth, and then consulting and agencies. These are some of the other kinds of training that people have, that they bring. There's another slide. This one's a little bit out of order, I think. Okay, so this is a really important slide because one of the key, let me have my water here. One of the key questions that we asked was, what are the top 3 areas of practice in which you work? And you can see clearly that decision support, care management, elder and geriatrics were the top 3. So you can see they're ordered. And then this next slide, this is called a tree chart. And so you can see from left to right, the biggest blocks are on the left, and those are the things that advocates do the most. And as you go all the way over here, you can see this little tiny blue legal box in the bottom corner. That's what they refer out the most. And so then this is the reverse of the tree chart that you just saw, where you can see that legal, guardianship, fiduciary, all those things are the most often referred out of the advocacy practice. And again, the full report will have the table and the data that's associated with this chart. This one's a little bit hard to read because the data's small, but it basically gives you an idea of how often people, the advocates that took this survey, work with these specific populations, patient populations. So pediatrics, behavioral, mental health, cancer, military, rare disease, adults, or older adults, Alzheimer's, dementia, and disability. The military VA is actually a very important, I don't think we have any military or VA people here specifically, but we do have a contingent of what do they call themselves? The care, yes, the recovery care coordinators that work with active duty folks that are injured and that come back to the United States. We have a very significant population of BCPAs in that category. So that's why that is included in here. And they're very interested in establishing a more specific certification. It's like a subspecialty certification for military. So we were trying to establish whether we have enough data to even substantiate that or not. So that's why it's in here. Healthcare background, there you can see pharmacist is on the far left. And then you've got your other over here, and that's what that other training slide that was out of order goes to. But a registered nurse is the purple. And then a whole lot of people, though, and that's just the one thing I hear every day when I talk to people on the phone all day. I don't have a clinical background. Can I still be an advocate? And so that's, I think, really a very important factor that we need to help people understand, that advocates come from extremely diverse backgrounds. And there again, you can see no clinical education, LPN, LVN, other things in those categories. Again, the full report lists all the things that go under each of those headings. Now, this next couple of slides I think are really important because it talks about, these are not the levels of education or training that the people that took the survey had, but what they would, if they were hiring an advocate, what do you think that advocate should bring to you if you were hiring them? So this is what they said, suggested level of education. So you can see most people think that your advocate employees should have a bachelor's degree. A good portion think they should have a master's degree. So I think that's pretty interesting. Suggested work-related experience for new hires. So you can see there in the middle, the two primary middle ones are over a year and up to 2 years, and over 6 months and up to a year, the two primary data points in the middle. On-the-job training, it's a little more spread out. It's probably a little bit more difficult to predict on-the-job training. I assume that would differ fairly substantially with the kind of advocacy work you're doing. Okay, So that's the end of the demographics. And Melynda's going to talk to you about the qualitative data, because as you know, those of you who took the survey know, every section had an opportunity for you to provide anything else you wanted to say. And there were a whole lot of pages of data, and Malynnda, who does this kind of work in her field, is much better at explaining that than me.
Thank you, Danielle. I will mention real quickly, we're going to be passing out a little one-pager that has kind of an overview of some of the data that we talked about, the process that we went through, so you can have that right away. But we will, as mentioned earlier, we are going to be posting these slides in the initial report, so you can, if you're struggling to sleep one night, have lots of really great information to continue to keep you up all night, because you're going to go, oh my gosh, what are we going to do with this? As mentioned, I am not a quantoid. I don't do numbers. They don't like me. I don't like them. I am a qualitative researcher, so understanding the stories behind and understanding the real depth of what people are experiencing, that's my jam. So we actually had, at every end of every of the domains for the skills and the knowledge, we had an open session that just said, what additional information do you have? What do you see that's missing? What do you think we need to know? And 69 individuals took the time to write out what they thought. And I went through all of that data and combed through them and looked for some themes, and this is what I found. So overwhelmingly, the participants felt that we were hitting it right on the head. That the skills were what we needed, what they were doing every day, and that all of the research, all of the lit reviews, all of the reviews of those documents, we did a good job, and that these were the things that were included. There were some comments about things being redundant and that we could collapse some things, but overwhelmingly, people really thought that we had encapsulated what we do as patient advocates really well. So that was wonderful to see. One of the things that I thought was really interesting is there was a couple conversations that happened in the literature that talked about the differences in the types of clients, the patients that we are working with. So these were I was able to break these down into those that are going to be our patient clients, whether we're working in the hospitals and medical settings, well, we are working with caregiver clients. So sometimes we're not working directly with the patient, but we're working with the caregiver who's taking care of that patient. And then also some comments about having families as our clients and some of the struggles and situations that come about with working with those families as clients. And I think that's interesting for us to think about, because each of those categories are going to lead to very different skills and knowledge. Right? If I'm just working with a family, that interpersonal communication, those ethical considerations are going to be far more important than possibly some of the financial things. And as we've talked about over the course of this conference, sometimes talking about the financial things with family members is not our place at all, because that's going to cause some conflict. So knowing who our clients are and the skills and knowledge that are going to be required to work with those clients is going to be really important. Also thinking about the needs of the clients, whether it is a long-term client versus an as-need client, an end-of-life situation, or a chronic care. The knowledge and information that you are going to need is going to be different. The skill sets that you're going to need are going to be different. Thinking about the types of clients that we're working with and types of care that we're going to be working with. As I mentioned, some of the redundancies were mentioned, small errors. I always appreciate when people wordsmith and will go through and take the time and write paragraphs about, I don't know if that's quite the word, and they give long paragraphs of words. And as a person who lives by words, I do not believe that it's simply semantics. Words really do matter. So we had some interesting data that talked about that. One of the things that I thought was really, really, really important to note is the current survey does very much, and we've kind of seen that through some of the numerical data that we received focused in on certain sets, so older, aging populations. And some of you mentioned, and I think very rightfully so, that we do need to really broaden the ideas of the types of clients that we're working with. So are there different skill sets and knowledge sets that we need when we're working with military populations? The answer is yes. When we are working with young adult populations, are there various skill sets and knowledges that we need to have? Absolutely. People living with disabilities, mental health issues, some of those are going to require slightly different subsets of information and skills, but overall, I think what we've identified is a very broad, very general, here's what we need to be doing, and then we can create some of those additional specializations that I think are going to be really key. So that was kind of in general what I found in looking at the qualitative stuff. Then I also started kind of thinking about what were people saying in terms of what their jobs actually, what we spend our time doing, what are some of the challenges that were coming through in these comments. And again, I want to remind you, we didn't ask anything personal about, like, so tell us about the struggles, tell us about what you do you refer these things in the qualitative data. All we simply said is, based on these domains, what additional comments do you want to give us? That's it. And I started kind of identifying ways that people were talking about these skill sets. And a lot of that did come to, here's what my job is, here's what I'm doing, here's how I view and use these skill sets and knowledge. And then here are some of the challenges in doing this type of work. So, what we said in terms of role of being an advocate. Empathy, 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 empathy. Lots of people mention the fact that to do this job, we have to be empathetic. Whether they use the words or not, they were really talking about the role of being empathetic. And I think that was of no shock to me whatsoever. It's kind of the same of not being able to spell HIPAA. And now I want to go back and see if anyone misspelled it. The ability to communicate and provide resources to populations that cannot navigate the complexities of the healthcare system. I mean, that's why many of us come to this. We've had experiences with our own loved ones, with ourselves, where we're like, how the hell does anybody do this? And we have that ability to translate that difficult information, to navigate those boats through those troubled waters. And the only way that you can do that, and I'm not just saying because I'm biased with a PhD in communication, we have to be able to communicate, right? Number one reason that we have some of the situations that we have is because people cannot communicate. Our clients sometimes can't communicate the needs that they have, the confusion that they have, so we get to spend some time doing interpretive dances and figuring out what they need. But the better skilled communicators we can be, the better we're going to be in doing this work. Knowing and being able to double check billing for errors and looking for other types of information, that's one of the things, doing that research, helping teach our clients how to do some of that research, but a lot of that was talked about that was the tasks that you were doing. You were figuring out, you were making those phone calls to insurance, you were making those phone calls to billing to figure out what's actually happening. So a lot of time being done as investigators and researchers. The ability to, kind of talked about that. Working with people in different areas. One of the things that because of the complexity of this field, a number of people said, I don't do this type of work, I don't need these types of skills or this type of knowledge because my area is just in the billing or just in the legal issues, is specifically hospital-based advocates. So you have specific policies and procedures and things that you have to do. You don't have the same flexibility or you don't have the same requirements as somebody who is working independently or for a private firm. So there was some real interesting conversations about, I don't do this because I'm this. And that really kind of spoke to as I think I mentioned, yes, the next piece, the number of times that referral was mentioned. And we've talked about this a lot these last couple of days, and the ways that we need to partner with each other. We need to have each other as family and friends and communicate with each other. And when I need help and I need to refer that out, I think there were, 17 different respondents of the 69 said refer. I refer to this person. I know my boundaries. I know what I can and cannot do, so I make referrals. And that was really, really encouraging to me to see that so many people were saying, yeah, no, I know my line. I can't do that. We did that with this study. I don't do numbers. I tried. I got confused and I went, Danielle, I don't know what I'm doing. Can I just do this part? Literally. So we know our boundaries. We know what we can and we cannot do. So referring, and a number of people mentioned that they wanted to have referrals. They wanted to know where to go and how to do those referrals. So that is going to be a key thing as we continue, knowing what we do, knowing what's not our strong suit, and having those connections to make those referrals when we can. So with that, what are some of the challenges of this job? Well, skills and knowledge of private independent advocates are way more widespread. So being able to have access in those connections is going to be huge. Right? We get asked a lot of questions across a lot of categories. And I said, if you know that that might not be your area, knowing where to go. And that's one of the great things with BCPAs is that we have a lovely list. And if you are a BCPA, we have a lovely list of all of the other BCPAs that we can get you in contact. There are directories, all the other organizations have ways of getting you in contact, and you having your own little Rolodex of people that you can talk to. And the one thing that I have learned in the 5 years that I've been involved with this organization, you're pretty darn friendly, right? So we can make those phone calls, we can ask those questions, and you'll get your kind of your pod of people that you're going to be able to talk to, but not being afraid to do that. And let's not be jerks, right? Let's not be territorial. Right? So I tell my students all the time, like, we're a community. We need to help each other. And we are a small community in comparison to some of the other healthcare organizations. And there are a lot of people that are kind of jerks and territorial and they don't want to share information. I'm happy to say that I've seen that in few and far between, but let's be a community. Let's not be jerks. Let's actually help each other out. The balance of providing information and support to family without overstepping and breaking HIPAA. We spelled HIPAA right? Of course we would. I just have to point it out because I really do find that funny. But thinking about all of the challenges, there's so much to take into consideration, and I do think it is a really important balancing act of how much do I give. I attended one of the breakout sessions yesterday that was brilliantly done and talked about information overload and health literacy. And that is so vitally important when we're giving information. And yeah, there might be a lot of pieces that we need to talk about, but we have to be able to space that out and do check-ins with our clients, with our patients, and making sure that they're understanding that information. And one of the things that I think her name was Colleen brought up yesterday is when you give a whole bunch of information and you say, so what questions do you have? And they go, oh no, I don't have any. Who is that a red flag? They should always have questions, right? I want to make sure that my students have questions. That's one thing. If I give them a bunch of information, I don't have questions is never a viable answer in my classroom. It's like, nope, I just gave you a lot of information. Give me some information back. What did you take in? What questions do you have? What was confusing? And if they say that they don't have any, then I ask probing questions, right? So what's your next step? What is your plan? What are you going to do when you get home? Who is going to be your contact? Whatever it is that you're wanting them to do, I'm going to ask a couple of questions just to make sure that they're doing that. So that's my own interpretation of what was mentioned. But knowing how to balance that information and how we're going to check and make sure that we're getting that information to people. Working with hospital staff given our continued fears and working as an advocate, I think it's been mentioned before, like that certification, being able to say that you're certified is gonna help a lot with that, because you're gonna have hospital staff that don't know what, patient advocates are. It was mentioned yesterday in the morning panel about calling up and just saying, hi, my name's Malynnda Johnson, and blah, 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 and 5 minutes later, I say, I'm an advocate for so-and-so. That's probably causing some of that tension between working with hospitals. So how are we presenting ourselves to the best way possible? So thinking through how we can best represent our clients and ourselves, and understanding that that is going to be a challenge. They have their own privacy protection things that they're trying to do, and we're also trying to advocate for our clients. So that's a challenge of how do we work amongst those different groups that may not always be as friendly as we would like them to be. And then finally, working with families and providers who have already made decisions for the clients. I think we've all probably had those moments, we've had those conversations where, well, this is what mom's doing. Okay, well, is that in the best interest of your mom? Or is this in the best interest of you and your needs and your vision? Because when I've had a conversation with mom, mom said this is what they want to do. Well, no, mom's going to do this. Oh, that's a fun little road to travel down. So how do we help with that? What skills, what knowledge can we gain? What experiences can we gain? What panels can we offer to help navigate those difficult conversations? I particularly love taboo and difficult conversations when I teach interpersonal communication. That's really my fun part. How do we do that? So I'm hoping that these areas and these challenges can be picked up by us in future organizations and future series and talks to help us learn how to apply the skills and the knowledge that we've identified with this study and practice them a little bit more so we can continue to do the great work that we do. So we're going to use a little bit of time that we have left to entertain any questions that you have about the study. Thank you. I think there's a microphone there.
Trish wants to know what's happening next. So as I mentioned earlier, we're going to be publishing the Phase 1 report, convening a new SME panel to validate the results of Phase 1, and also to help us establish the validity and that what we've already published is accurate and that we can move forward. Like I said, there are a couple of crosstabs related specifically to the work setting differentials where there are some psychometric differences on certain domains. So the subject matter experts will have to go through that and help us decide, is there a difference or is there not a difference? And once we get that particular part done, then we'll be able to validate the remainder of the survey with maybe another subject matter panel and hopefully have the final statistical report written. Probably won't be before the end of the year, but it will be shortly in that time frame. And our hope is that we will publish the full report in as many journals, academic journals, or other professional publications that we're able to get to publish it. So, you're welcome. Yes, you have a question?
Yeah, it's a comment and a suggestion rather than a question. I think that the work that you've done is tremendous. I would not have thought that people can break down patient advocacy in that amount of detail and then structure the exam and the certification. I didn't know that the board existed until, January, and I've been doing patient advocacy for 12 years or more. The only comment that I had about it was the certification is centered around the American healthcare system, where it is privately provided, and the billing and the insurance and the private infrastructure is entirely different than universal healthcare systems, which is,
Right.
if you're branching internationally, this is something that maybe should be considered for international certification. So I took sat the exam. I'm certified now, but I don't think if this is the only thing I know that I would be able to work back home as a patient advocate, because I wouldn't know the first thing about accessing the system or how it works or how to measure the success of the business. The other part is that in universal healthcare systems, it's not possible for me to have a private paid business as a patient advocate. So the question for me would be how to put together a sustainable nonprofit business to help the patients in that context. Because if they're not paying for healthcare, they're not likely to pay for an advocate to access that healthcare system. So my suggestion for this is to probably do something like what the AHA or the American College of Surgeons or any of the institutions that do branch out internationally, to have the core exam and then an international component where, for example, you'd have the MENA region branch that has that bit for that type of healthcare systems done only for that part of the world.
So just to address that really quickly, while I was in my presidency in this last term, we did address this issue about how do we want to handle this, because the PACB is currently based on the American healthcare system, and as you read through any of the materials we have, we make it very clear that the exam is based on the American healthcare system. We aren't at a point, and because of this initial job task analysis and getting a certification through the ICE accreditation and things, we're not at a point where we could diversify the system, and we don't have a credentialing system. We had not been through the initial job task analysis to have a set of data robust enough that would allow us to diversify out. And so we intentionally made the decision when we went through this process and when we were putting the exam online the first time around, that we would stick with the American healthcare system, since most of the advocates were practicing within the American healthcare system at this time. And so we do know we were debating about whether or not to have an international version and an American version at this time. And that is something that's very much on our radar. We're very attuned to that. We have our Kuwaiti and Saudi representative here. We have individuals who are practicing in other countries, including Canada, Great Britain. We have a board member who is from Great Britain. So we're aware of that factor, but we're also keenly attuned to the fact that the vast majority of individuals who are practicing at this point come from this system, and that we had to get this initial set of data and validity under our belts before we could then expand and move from that. But we had to have a starting point. And
Absolutely.
so we greatly appreciate your comments. And as we look to make that leap to those next steps from this initial starting point, we'll have a good foundation from which to be able to make those next steps.
All right, thank you so much.
So thank you so much.
You.
Hi.
And to Tricia's point, when I was telling her what the next phases are, of course, the most important point, and the only main reason we do the job task analysis in the first place, is to ensure that the blueprint that supports the exam, upon which the exam is built, is still matches up with what the job task analysis tells us that the advocates are actually doing. So that will be, of course, one of the very next steps is we'll be analyzing that data to see if there need to be any adjustments in the percentage of questions that go in the various domains, and or if there are any tweaks that need to be made in the actual layout of the domains. So, of course, that's kind of we just know that's what it is. So we just assume everybody else has ESP and knows that that's what we're doing with it too. What's your question, ma'am?
Yeah, I wanted to find out, and if this is too broad of a question, maybe I can have a discussion with somebody else that's a little bit more better able to answer it. When it comes to mediation, I think the family dynamics are a huge part of what we all deal with at least in the portion of advocacy that I'm in, which is sort of the transitions and decision-making with families, I would love to know this much about mediation so that if it's not somebody that I would need to refer to mediation where they're just completely log-jammed, if there's a way to incorporate finding that information that I would be able to, again, have a small knowledge base if it's not this logjam with the family. So I don't know if there's anybody that has any information. We can just talk later.
I don't think that the job task analysis would have any relevant information that would be of help to you on that, but I'm sure we can connect with, a variety of folks who will definitely have information that they can share with
Thanks.
you to be of support.
Hello.
Hi.
I have a simple question. I was just wondering, I noticed that they offer the test twice a year, and was just wondering, are they considering offering it more in the future, like maybe 3 times or every quarter?
Right now, we offer it 2 times a year for a very specific reason. Because we're still new, the exam is still young, the exam commission, so the commission is it's a semi-separate entity that still reports to the board of directors, but they look at the exam results after every single cohort to ensure that every item on the exam is performing statistically well. And occasionally, because as you know, we have 150 questions on the exam, 25 of those questions are pilot questions, meaning they're being evaluated to determine if they if they are going to be performing well enough statistically to be used in a future version of the exam. But occasionally, we find that there's an unexpected outlier that maybe 2 of the answer options could conceivably be correct instead of just a very clear definition based on our standards that the only one. Anyway, the bottom line is occasionally they have to throw a question out or they have to make an adjustment that allows for A and B to be acceptable answers instead of just B. So the reason that we only do that 2 times a year is it gives us a large enough cohort with every testing cycle that the exam commission can take a look at that and have enough data to be able to make those determinations, and also then to be able to make those adjustments on the back end. Down the road, I expect that will probably change as we get more refined. We have a much larger bank of items because our item bank is still relatively small, and the items have to go through a pretty rigorous, you think you're just writing a question, but the exam items have to go through a very rigorous review process to ensure that they are fair and equitable, and that they can be answered equally across all the various diverse groups of folks that take the exam. So once we have a much more robust item bank, we'll probably be able to deliver it more frequently, and we'll probably at some point be able to do more instant scoring as opposed to having to wait to the end.
Okay,
But,
thank you.
But I can't give you a timeline. I don't know when that's going to be.
Okay, thank you.
Last question.
Okay, I'll be quick. I have just a couple quick questions. First, I wanted to know, what did you find most surprising in your results? And then second, I was wondering, as someone who just took the BCPA exam, did any of the results influence the design of this current test or not at this point?
None of the results from the study have been incorporated into the exam at all at this point. So that's all still for future. What was most surprising? Yeah, the thing that was, Chris just said, the perfect correlation. We actually thought we would see, some sections that were just like, I know that's ridiculous. Nobody ever does that, or this is not important, or we don't do it very frequently. But the fact that it is almost a perfect correlation was actually the biggest surprise. And the other biggest surprise was how hard it is to get people to do the survey. Oh my gosh. It was, it was long. We recognize it was long. And the next one, like Chris was saying, we will have to do this again. The next one will be much more refined. It'll be much shorter. But until you actually have that baseline,